Sure. Should I share the screen?
Sir, we will do it, sir.
Good evening, sir, Rajagopal sir. Good evening to the panelists, and good evening to all of you. Thank you for giving me this opportunity to present a case. This was really a chance I got because I'm working with Dr. V.P. Gangadharan, well-known medical oncologist for many years, almost since 20 years. And abroad also I was in medical oncology. So one day I was just talking to him that I could help in the counseling of patients, though I'm not a trained counselor. Since I know about the oncology regimes and other things, I could help him in at least telling what is needed. So this we started in Lakeshore some years, 2 years back when I rejoined 2018. And it's still continuing in a small way now also. So I just wanted to present my experience on that. Yeah. Now the famous, am I audible, sir? Everybody?
Yes, sir.
You are audible. Yes, thank you.
Thank you so much. The C word, of course, the word of cancer is for the patient and the family, it's definitely a stigma in society. When they come to know of it, it's a big fear of the unknown. They already, there are perceived conceptions, like many of them think that's the end of their life, and it is a big disaster for their family. It is also to a large extent. Though things have changed, these conceptions are still deep in our society. And they also have your physics, the disfiguring, the loss of hair. I think is my connection okay?
Sir, the voice is breaking a little bit. Can I off your video, sir?
Yeah, please.
Yes.
Yeah.
Yes, sir. You can continue, sir.
Sure. So the other thing is about the fear of physical issues like loss of hair, cosmetic differences, changes that happens in the physical during the treatment part of it. And then the fear of social acceptance, what the society would think of it, how they would go about with the treatment. And definitely the fear of financial problems, because certain treatments are quite costly. And even from the start, from the investigations, the invasive procedures that are likely to come, the surgery, the radiotherapy, all these are quite costly. And some of the monoclonal antibodies are very expensive. And the problem is it's a big financial burden for the whole family. What about the career? What about the future? And of course, there is always the imminent fear of death, like a Damocles sword hanging over the whole family. Fear of the treatment. They heard so many things about the treatment, the side effects that these people have to encounter, and the fear of pain. These are the common things that you see whenever a family diagnosis, anybody in the family gets diagnosed with malignancy. Yes, please. Can I have the next slide, please? Yeah. Now, the anxiety on the diagnosis for the patient is generally because of there is a lot of ignorance of the disease. There is discomfort in the new situation. There is, to a lot of people, there's a lot of guilt and anxiety also, even for those who have not been doing anything. Like, for example, many of the smokers, those who drink and all, they feel definitely their habit had brought it to them. And even otherwise, there's a lot of guilt and anxiety, whether their lifestyle or how they behaved, or in so many ways they are guilty and they're anxious about what is going to happen. There's a lot of confusion by misinformation. They're not knowing what's happening. Then, of course, there is denial of diagnosis, like any other bad news. And there is difficulty in trusting is there. This is for the patient, and for the families, of course, collusion is a big barrier. They don't tell the patient. They try to protect the patient by not telling anything to the patient, trying to keep him or her away from everything. And the fear of diagnosis, is it really a malignancy? How bad is it? And they're afraid whether the news will go to the friends and other because of the state again of ignorance and lack of knowledge. Yes, please. Next slide. Can I have the next slide, please? Yeah. Now, generally, what happens in any oncology center when they come as a new case, this is what happens in day one. Their history is taken by junior medical officers, and they're examined by them, and some basic tests are ordered. Usually, there are set patterns of tests also, like for example, if it's GI malignancy or if it is hematological malignancy, there are routinely certain tests which could be ordered also. So these tests are ordered like bone marrows, invasive procedures like, for example, a bone marrow and LP could be ordered also. Imaging, of course, CTR and MRI and ultrasound. So many of these tests are ordered in day one itself, or they'll have to do it and then come back. So it is all, it's all happens so quickly. And so there is actually no time to think of anything. They're overpowered by the happenings and they're totally confused. They fear the outcome and there is a lot of frustration also. So it all happens in one day. They come with this bad news and then somebody examines them and then asks them to do all these things. So it's a lot of happening on the day one. Yes, please. Next slide, please. Can I have the next slide? Yeah. The normal method is the consultant usually meets the patient and the family. Either it will be after the tests, basic tests are done, or in the beginning and later again after the test, and to counsel them and tell them the line of treatment. This is what happens in the center, and most will do it perfectly because they have been doing it for ages. It's their job. So they don't require anybody like me to come in between and help them in this job. They can do it wonderfully well. No problem is there. Now, the disadvantages here, which I found out was, one is that there are time constraints because most oncologists are quite busy. They have a lot of patients to be seeing even on the routine. They come for the treatment or they come for review and then they see the new cases also. So they're quite busy, I think. And many patients and family are overwhelmed by the whole thing. And they fear to ask silly questions to the oncologist. So they just keep quiet, even though they have every right to ask, especially in our country. Abroad, I'm sure they will not leave any stone unturned to get whatever they need to get. But here, people are generally overwhelmed and they do not want to ask silly questions. And some oncologists also sometimes do not tell everything at a stretch because they don't want to frighten or create more anxiety for the patient. So they may be telling in steps, like, for example, you go ahead with surgery, and it may also be needed like that. For example, after the surgery, only based upon the clearance, they may require adjuvant chemo or not. Or they may, whether the colostomy can be closed. These things can be done only in steps. You cannot sit on day one and tell everything. So that could be the reason. Some people also put it off for the future. So at times, some families or patients need a bird's eye view. If you can tell the whole thing, okay, this is going to happen. You will have to have treatment for about 6 months, and then the review will be there. And then most of them are obsessed with the staging. Many of them, the first question they ask is, doctor, what is my stage? So I generally tell them the stage is more important for the person who is treating you rather than for you, because somebody with a stage 4 who is coming inside walking is much better than a stage 1 who is coming in a stretcher. So when I tell them, generally they feel happy about that. So staging is more important for the person who is treating, who will decide on what your treatment is rather than for you. So don't get obsessed with the staging. Just leave it. Let the oncologists do their job. You don't need to break your head on the staging part of it. So that's what I don't know if I'm right or wrong. I usually use that method. Can I have the next slide, please? Yeah. So In first day counseling with a palliative physician, what are the advantages? The advantages is maybe they are less intimidating, and the patient and the family feel freer to ask more questions. And it's like a sort of buffer before the final exam. Somebody is there to bounce your anxiety, and then they could answer. Now, what are the disadvantages? The disadvantage is the label or the board that is outside that you're a palliative physician. Strangely, when I started this first day counseling, I was telling Dr. VPG, sir, but most of them are going to feel odd coming day one. They're coming to see a palliative care physician. Why should we go to him? Like only when I am not going to be treated. So that would be a big hindrance, I thought. In fact, it was not. I was really mistaken. Not even one person had asked that question. How come I'm coming and seeing you? What is the need for my seeing you? But they were quite glad to talk, and they know by now that a palliative physician is also for counseling and for talking and for making them comfortable. In that sense, I was quite happy to understand the acceptance in society, especially in Kerala, because of the efforts of people like Rajagopal sir. Palliative care is well known here, and we are more like friends to the society rather than anything. So in that sense, this was a clear case of, I never found anybody asking me that question. I don't like coming and seeing you on day one. Why should I? Nobody has asked me that question so far. So the second, so this I thought can be a disadvantage in some places. The other thing is the knowledge that this person is not going to treat me, treat my relative. This person is just going to talk about it. He is a doctor, but he's got nothing to do with the treatment. And the third thing is they may doubt about his knowledge about oncology. That's very important also, because here the counseling is not done as a professional counselor. We are not trained. I'm not trained in psychology. I'm not a professional counselor. I know only the basic tenets of counseling. Maybe I have some amount of empathy because I have gone through a lot and I have been working in this field for some time. So that empathy is there. That is the only thing which I have. But for the past 20 years, I've been working in oncology. I know most of the regimes, though I'm not, I would never call myself as an oncologist. I don't keep abreast in the research or anything like that. But the basic thing, if some CA prostate come, I know what is going to happen. If I get a CA breast, I know what is going to happen. What are the possibilities? So I'm very careful in telling, look, I'm not going to treat you. I'm not going to tell you what is going to happen. The person who is responsible for that is there. I'm just going to give you a bird's eye view of what could happen. And then the question comes, what is radiotherapy? What is chemotherapy? They don't know anything, and they're totally confused. Many of them ask me, radiotherapy, does it burn you? Chemotherapy, is it all poisonous things that you people inject? I mean, there are so many doubts are there in a lot of things. Even educated people I see coming with such sort of doubts, and to them we can confidently say, and the knowledge in oncology definitely helps here. And the other thing is, of course, the disadvantage which I found is collusion. That is very much there. I will talk about it later. Can I have the next slide, please? Okay, what are the benefits of a first day counseling by a palliative care physician who has an idea of oncology or in oncology is, one, you can give a bird's eye view of the disease, the treatment and possible outcome. Like, for example, if a germ cell tumor with an early stage comes, or a Hodgkin's lymphoma comes, or an early stage breast cancer comes, we can confidently say, look, you're going to get a cure. That makes a huge difference. On day one, we are telling you, look, the chances of your getting cured is very high. If you tell that, you can see the faces literally burning bright. Of course, this is going to be told by the medical oncologist, but it makes a big difference even before they start the test to know that they have a possibility of cure. And even the other ways, we are not going to depress them by telling there's no thing. We can definitely say the advantages of doing treatment. And if in a situation where the treatment is not required also, we can always say that supportive care can be there. That is the another advantage of palliative care physician, because side by side, we can also address their pain and other supportive issues from the beginning itself, we can do that. So regarding when we talk about the treatment or outcome, it has to be in sync with the particular institute and the plans of the consultant. We cannot talk the types of regimes which are not used there, because that might, counter the whole thing. Because if you talk something and then the consultant says something, you could really put trouble for them. You are only assisting the team. You are not antagonizing the team. So we have to be very careful about that. So I really don't enter into the management. I'm not qualified to that. I don't ever do that. I always say that that part is left to the professionals. I can only give you a broad idea of what is this. So the regimes and the cycles and the radiotherapy details and other things will be talked by the concerned specialist. I cannot talk about that. The other benefit is many of them do not know about the surgeries in surgical oncology or even radiotherapy. As I told you, they don't know what happens during radiotherapy. Many of them think that they have severe pain during radiotherapy or burning sensation. And what are the side effects during radiotherapy? They'll not be able to take food. And of course, chemotherapy, you all know it is got so much of stigma about it. And what I generally tell them is, what is chemotherapy? It's just therapy with chemicals. Aren't we using chemicals for everything? Even paracetamol is chemotherapy. Only thing we are using it in oncology, you call it by that label and that got stuck. So everything is chemotherapy. So generally that it is the truth also. It is just synthetic drugs, certain regimes are used. So we tell them, I tell them, like, for example, it is given in cycles, maybe 2 weeks or 3 weeks. And then what happens, how the count drops, neutropenia can take place. At times, in certain types of chemotherapy, you lose hair. There could be a loss of appetite. There could be some mucositis. And in general, it will not be, once the regime is decided, the oncology people are going to talk to them in detail about the chemotherapy and the side effects. So we can talk in general. And generally, they feel happier if they know what is the surgery and what is the radiation. That is what is all about this radiation and what is all about this chemotherapy. And then, of course, many of them Google, and some of the youngsters are also quite knowledgeable. They ask about immunotherapy, targeted therapy. Some of them tells, why you want chemotherapy? Why can't you give targeted therapy straight away? If it is costlier, I don't mind. Then we tell them, no, it is tailored to your need and not one is better than the other. Even the common question that we have about investigations is, why don't you do a PET? I can afford it. Why do you want to do an ultrasound? Then they think the PET is better than an ultrasound. No, I try to tell them it is as per the indication, and each one has got its own place. So it is not about the cost, it is about the need for the patient. So generally they understand about that. And then the side effects and the issues during treatment and the cost, most of them, even when I was working in Lakeshore, now I'm working in Indira Gandhi Hospital, many of them talk about the cost, because it is a big issue, how much each session will cost. But then again, I would not be able to tell the exact cost because I don't know what the regimes are, but that part will be told by the thing. But I tell the possible costs could be this much. To a certain extent, I can tell them roughly. And whatever the available concessions, I do know that there are certain ways you can apply to the local MLA for the Chief Minister's Relief Fund. There are certain the insurances. And in a broad sense, I can tell them, you start trying out for these things. We can give you a good medical certificate to apply for them. And even there are railway concessions, like for example, for the patient who is on treatment plus the escort, they get almost 100% concession. Even AC coaches, they get it in buses almost free in KSRTC. Many of them coming from distances, they don't know, they come. Now of course this COVID is there. Earlier they used to hire these costly cabs and come all the way, and some of them are quite poor. They come from all the way from Kannur. They tell doctor it's quite expensive. They say, why don't you use this railway concession? I said, nobody told us I said, no problem, just get the form and from the railway station and give it to the station master. You will even get assured seat as a cancer patient. So the government is doing a lot. Only thing, it doesn't reach the people. I would be very happy to use my counseling for those kind of things also. Then the most other thing is how to accept and cope to the family as well as to the patient. And finally, in collusion, of course, I'll talk about the collusion. Explanation of the collusion is very important. Since family and patient meet the palliative care physician on day one, uh, in another way also it's easier when their real need arises for them to meet him, whether they have pain or whether they are transferred to palliative or supportive care once for all, or when they require supportive care along with it, they are very familiar with us, with me. They have seen me earlier, and it's not like they are pushed into palliative care because they want nothing more to do with them. Well, they know I'm part of the team, and they have met me on probably on day one itself. So in that sense, also it is a great help. And they also have an anchor during treatment. They come to know of us. Many of the relatives I find during chemotherapy sessions when they have time, as I am not very as busy as the oncologist, most of the time I have plenty of time, and they come and have a cup, bring, some of them even bring a cup of coffee just to sit and chat with me, and they feel very happy. I still remember a ovarian malignancy lady's husband used to spend a lot of time with me. He will come and tell all his issues, his financial issues, his one son's issue, So it used to be an outlet for them also. So in that way also the palliative care physician can function as a sort of moral support for the family or for the patient. There have been several patients who come for just for a review, but they never fail to come and see me. So it is all because of the rapport we established during the first time and later on. Next slide, please. Can I? Yeah. Now, my experience in the first day, me and Dr. Betty also, we are colleagues in Lakeshore. So our experience in first day counseling, I rejoined after coming from abroad in 2018. So 2 years I had done this. The time when it is done is on day one, if possible, or within a week after history taking, before or after the preliminary test, before or after meeting the consultant. Sometimes they will have to meet the consultant first. So that's the priority. And then if they have time, they come and meet. Either it is first day, or even when they come for the first chemo or something else, if they are not able to come earlier than that, that also can happen. Sometimes I go into the chemo ward also and see. At that time, it was around 600. Now I think it's around 800 patients I have seen. I am continuing this also. Can I have the next slide, please? Now, talking about collusion, again, this is just my experience. It may not be 100% true. Actually, I feel the Western definition of collusion may not fit our way of living. Somehow we are more, we give more liberties to our family, I feel. Some patients, in fact, prefer the family to receive information and take decisions rather than themselves. I have seen so many people telling me, look, I need to talk to you. I need you to tell me whether you're okay with it. They tell, no, everything is decided. My family, my children tell it. I don't want to hear anything. Even that I heard. And I feel collusion is something which just disappears when we really take the families into confidence. And generally, my suggestion would be to avoid lectures on the harms of collusion in a big way. What I generally do is I include the family as a team. And I'm quite flexible on collusion. And it takes time to resolve. It cannot be done on a single visit. So generally, I talk to the person concerned. I said, look, we understand fully well why you're being protective about your family member. Even if I was in a situation, I would do it. But it has been found it's not good because it's going to be an you're going to do acting, both of you, for a long time, like he would know, obviously, using some common sense, that he is coming in for treatment of malignancy because he's going to come for a chemo ward or he's going to go for radiotherapy, and he knows his people are not going to tell about it. So it's just play acting between you two. How long will you continue that? So in another way, we don't use words like cancer or anything like that. In a nice way, we can put it to him, and I'm sure he will understand. And his acceptance is very important for the treatment, and your acceptance also. So let's function as a team. I will help you in this. So generally, when we tell that even on day one, they're all happy to uh, work. I haven't come across anybody who says no, no way, you cannot talk to him. So even though they initially they told they will come in the front running and tell doctor, please, he doesn't know anything. And then I make them sit and I understand. And by the end of it, they are fine to tell with the patient also. Can I have the next slide, please?
Dr. Harimon, can you speed up a bit? We are running out of time.
Sure, it's almost getting over, I think. Now the treatment elaboration and allaying fears help. First day counseling can inform families of the financial assistance possible, and the palliative physician can also arrange for easier, less costlier visit in discussion with the team. Like for example, some of the chemo sessions can be taken in the local hospital also. So when there is a financial issue, we can talk to the consultant and maybe we can do some help in arranging that also. Next slide, please. Yeah, the outcome. Now, outcome is more cheerful, more acceptance, less denial, and less pollution. Again, another very important outcome is they are less diverted to unscientific interviews. This is what we find in most of the oncology centers. They come and take the investigations. Before taking the treatment, they find somebody else telling them there is some alternate treatment, and then they go back and come with a very advanced stage that we could do nothing. To a certain extent, this can be stopped if we talk to them on the first day itself about not getting into this trap. Then they accept, they meet the consultant in a more acceptable frame. There has been a buffer from the initial shock, and this should continue and to be keep in touch for doubts and anything. The physical complaints, etc., like pain, nausea, hair loss, anorexia, bowel issues, are all addressed. In fact, I started opioids also on day one who have come for counseling, not for pain. But when they asked, they're already on semi-opioids, and then we straight away start them opioids, they become better. The pain also comes down. Next slide, please. Thank you. Thank you so much.
Thank you, Dr. Harimon, for that detailed explanation. So we have Dr. Rajagopal, Dr. Sunilkumar, and Dr. Ann joining with us. Over to you, sir.
Can we
Thank
video?
you, Doctor.
Yeah.
Sorry.
Video.
Thank you, Dr. Harimohan, for sharing your experience with oncology palliative care. You have been taking two roles, even though you are mainly working as a palliative care physician. So, are there any questions to Dr. Harimohan regarding any of this?
This is not a question, but a comment from our US context. We are also in the cancer clinic. And I do believe that the role of the palliative care physician, seeing people early, we would have our entire team, social worker, physician, and nurse, also assess the caregivers to find out how they're doing. And this has made an enormous difference in the course of treatment. And I agree that seeing people at the beginning means that it's they don't just bring the palliative care physician when there's bad news. There's obviously bad news because there's cancer, but it's not when the oncologist is done with therapy, but rather we're there to help with symptoms during chemotherapy. And when I introduce myself on that first day, I'm sure this is something you do, Dr. Hardman, is say, I'm here to make sure that your chemotherapy and radiation is as successful as possible and that we meet your needs. So I sort of align myself with their goals at that very scary time. And it makes a very big difference. Our oncologists are also very rushed. And so I think it makes a difference to have somebody there that's going to be there for them during the entire course of therapy. I also like to say that though initially I help treat symptoms, if I get in there early, I can also address the far more important things, is what brings dignity to their lives, what's important to them, how can we make sure to value things going forward. One of our colleagues, Dr. Chris Booth, has just written an article about when is it time for cancer patients to stop spending time going back and forth to chemo and radiation, and to spend time doing the things that are most important to them. So I'll make sure that article is sent on our WhatsApp. It especially striking because the three people who wrote it are oncologists themselves. So.
Thank you. Anybody else has any experience on this?
I just want to say one thing. I was able to do this luckily because I had worked in oncology for a long time and I was quite confident of talking to them about the. I definitely feel in palliative care, we definitely require a basic knowledge of oncology. That's very important. That's my feeling. Of course, it's not restricted to oncology alone, but to a large extent, I feel a knowledge of oncology helps, especially in cancer patients. Just my suggestion.
Okay, Dr. Shashidharan also says it is good to have some basic knowledge in oncology.
Rajagopal sir, I would request you to give your suggestions for this. How do you feel about it?
Yes, I will totally agree with you. If you are working in a cancer department or cancer institution particularly, the more you know oncology, the better, and the more closely we work with oncologists, the better. But as far as the palliative care scene as a whole is concerned, for us, it's about 50-50. Half our patients are non-cancer patients from various disease states. And I am told that if we get palliative care across to everybody who needs it, only about a quarter of the patients or less will be oncology. So what, Hari, you mentioned about knowledge of oncology is very valid. But then people like Anne Broderick are sitting really pretty because she is a general medicine person. The more we know medicine, the better it is for us, no doubt about that. But understandably, if you are, I mean, like when we were seeing even more cancer patients, there was a time when 80% of our patients were cancer patients. So at that time, we actually started doing sessions on oncology, but then it is more spread out. But thank you for being able presenting your story, and it's good that you are working so closely with oncology.
I had the benefit of initial class of palliative care as the only student of Dr. Rajagopal, because 7 other people did not join. So he saw to it that I came for all the classes and I gained a lot. I'll always remember that. Sir, no
Oh, certainly, Hari, certainly.
I was your only student.
I see, okay.
Privilege I carry always.
Thank you.
Can I ask a doubt?
Yeah, please.
In our country, I've seen that this oncology sometimes is oncologists overtreat cancer. They don't have even unnecessarily they treat, and there's not much patient is not told, autonomy is not there. Even if there's suppose there is an improvement, there may be improvement only for a few months, but and eventually the patient is going to die. So in such a situation, what can palliative care physicians do?
Is it to me? Or, am I supposed to answer, or the faculty?
Dr. Elizabeth? So you are asking about a patient who's near end of life or advanced malignancy and over treatment by oncologist.
Yeah,
Is that
yes.
what you meant? And in such situation, what a palliative care physician can do?
Yes.
Okay. I think Anne, can you take that question?
Well, I'm sure Dr. Hari has a good take on it. This is why it's so important to have a relationship as early as you can, which I'm sure you're doing, Dr. Elizabeth. I would call this a dance that I do maybe as many as 5 times a day with oncologists and patients and families. And the way I do this, I try to keep my relationship strong with the oncologists, but I ask them pointed questions, and I ask patients and families pointed questions. The questions I ask the oncologists are, what are we gaining with this therapy? That might not be a question that you can ask the oncologist. You may not have the relationship yet to ask them. And then to the patients and families, I ask what's most important to you. And I think you may find that what's most important is not living longer, but living at home, being at home, being surrounded by family. I think the reality in India is so different from the United States, but I just want you to know that this is a problem that we have in the United States, that oncologists frequently believe that one more treatment is appropriate, and it's often one too many. The patient lands in the hospital in an ICU. So all I can say is the way I got to this spot is that I have helped oncologists out of very tough situations. And so they now listen to me because I have built a relationship with them. so that I can ask those kinds of questions. Now I can see Dr. Hari is smiling, so I will turn things over to him for more of an Indian context. But this is a problem, and as I say, Dr. Booth's article addresses it as well, which I'll include soon.
Dr. Ann, that was a wonderful feedback. You are absolutely right. I mean, there are what you said, Dr. Elizabeth said is also very true. There is a tendency to overtreat by many oncologists, but at the same time, there is also something called as a palliative treatment where we use all the modes, which will increase, which has got only one goal, to increase the quality of life. If, for example, we have seen a small child about 6 or 7 years who had a huge head and neck swelling, and this was very advanced locally and also metastatic. So absolutely no scalpel, no surgery should be done for the child. But we had tried, she had severe pain because it was pressing on a nerve, and there was no relief with opioids. There was no relief with nerve blocks. And then finally the head and neck surgeon said, can I remove a part of the tumor that is pressing on the nerve? We agreed for it after discussing with the family the pros and cons. At least it was only for relieving the pain, and it did relieve the pain of that child at least till she till she passed away. There are plenty of other examples also, like we give radiotherapy for pain specific spots. Palliative chemotherapy itself is given. These days, people with metastatic disease live longer. When I was doing my radiotherapy those days, I remember those with even bone mets in breast cancer used to surely die in about, say, 1 or 2 years. But now they go on for years. Newer therapies also have come. So stage 4 or metastasis itself is not an end of the treatment. There are so many regimes are there, so many possibilities are there. But again, the pros and cons, the discussion between the person who decides on the treatment, how much it helps in the quality of life, is it all worth it? Or just leave alone, just giving supportive care. That's very, very important to a large extent. So it mainly depends upon that. I can give you several examples where palliative intervention has helped to a certain extent, and also the other way around. At times, the continuation of treatment makes absolutely no sense, but probably to feed the ego, or even sometimes patients also pressurize. They want to have treatment, and they say, continue, give us something. We don't want to just stop everything. So it's both ways, but generally, I think oncologists, whoever I have worked with, are quite fair in this respect, and they know the pros and cons. They explain it to the patient and the family, and some of them do take it up, and they're happier with it also. But once we understand that there's no sense in doing it, definitely we should counsel them for supportive care only, and tell them that's not the end of it. People in supportive care, in fact, some of them have improved and gone on for 1 or 2 years very happily also. That also I had seen. So it's a matter of how sincere you are to your conscience, and how sincere the team is. That's it. But we cannot just have barriers and tell, okay, this is it. Stage 4, no more treatment. No, it depends on the performance status of the patient. It depends upon so many things. It depends upon the outcome. Will it help in some way? In some way, will it relieve the patient? Some symptomatology, it does help. But as Dr. Elizabeth told, there are incidents of that also. We hope that is avoided. And as Dr. Ann said, to a certain extent only, we can interact and tell. We cannot sit and tell, no, don't do it. This is what the oncologist is telling you. I don't think in any situation a palliative care physician can address that. So only with discussion with the oncologist we can help.
Dr. Elizabeth, do you have a relationship with the oncology doctors? Are you able to meet with them? Do you have an office that's in the same building?
I work in an organization which gives palliative home care. So we don't have direct connection with the oncologist. And also, I don't think we should have a relationship with the oncologist. And I fear how it will be taken by the oncologist if like we express a difference of opinion and all. So I have never attempted, like I am not working in a hospital also.
Right,
And I
right.
connected with oncologist.
Dr. Elizabeth, sorry, and you were saying something.
Oh, if I could just finish this thought. Early on in my career, people, I would walk into the oncology clinic and all my former colleagues would avert their eyes. But slowly but surely, by talking to them, sometimes I ask for their advice on how to treat something. How would they do this? Over time, I have developed a relationship so that I'm not always about stopping therapy. I'm sometimes, do you think the treatment of this pancreatic cancer would help their pain? Help me understand this is my very common line. So engaging the oncologist as a teacher, not always, what are you doing this therapy for? You're bankrupting my patient. I'm not suggesting you do that. I'm suggesting that you talk to them and build advice, and you'll find that you actually have colleagues that will help you with time and others that will hang up the phone on you. And that's just the reality of building palliative care. Now they all call me. They say sometimes I have to look Ann Broderick in the eye when I order this chemo, so I know I won't order unnecessary chemo. That's the level that we're at right now, but I worked hard. This is 20 years of work to get to this point with oncology. So engaging them early with phone calls, not about stopping therapy, but for advice is a great way to engage them. I'll back off because I can see hands are raised.
Thank you, Dr.
Dr. Elizabeth, other hands are raised. Yes, I'll be brief. No, I'll be brief about this comment. But Raju and Sunil, I have two more things to show, sharing screen. That will take about 5 minutes, but you see that we are already at 7:48. And Dr. Elizabeth, the particular issue has been answered already. The summary, I think, is unless you build a good relationship with the oncologist, this issue cannot be sorted out. And it's not about oncology alone. This happens with all, whether it is nephrologist or cardiologist or pulmonologist. If we are at odds and criticize the specialist, that's a very bad thing to do. The patients get confused. We have a bad relationship. So I'll stop there. Sunil, if we cannot have 5 minutes, I would still like 3 minutes later. But now Deepak wants to say something.
No, sir, it's about that the oncologist's comment. I think all of us are very clear that palliative care is more than just oncology. It's about a lot of other specialities. And there's no two ways about it. And I'm not even trying to raise this thing. But another fact, at least in our context, is that palliative care, the resources are very limited in India currently. So somebody is always going to lose out. So suppose you can only see 100 patients out of, there are 1,000 oncology patients and 4,000 non-oncology patients. You can only see 100. So I think the debate really is about, do you focus 100% of your resources to see as many oncology as you can and become very oncology based, or do you stick with the principle of no, I will see everyone? I think there are two sides. I don't think it's as black. Ideally, we would see everyone, but I could see why some people, try to focus more, especially because because the other diseases may, there will be at least somebody else who will see in cancer. It's not. But again, I'm by no means saying that that is the ideal way. But looking at the limited resources, maybe specialist palliative care more geared towards this thing, and the other specialties being geared towards palliative care for the rest of these things. Perhaps I don't know if that's a very sensible view, but I think that is the other side of the coin. So just wanted to bring that up.
So I wanted to share this screen with you. Can you see the Choosing Wisely India?
Yes, sir.
Specifically in relation to the oncology practices. This is from the National Cancer Grid, a conglomeration of about more than 200 cancer institutions in India. They together have brought this out. I have shared the link on the chat box. This actually spells out several things that should not be done. Dr. Raji has commented on the chat box. How do we know? I mean, there are new therapies coming up all the time. How do the oncologists know that nothing can be done? This nothing can be done is not true, but who is to decide? We have to be open with the patient and tell them, okay, these are the chances. And we have to help them to come to terms of acceptance. There is no easy way. So there are several things mentioned here, including the fact that in advanced cancer, advanced incurable cancer, patients should not be admitted to intensive care units unless there are some specific reasons, which is mentioned. So including that, what should not be done has been spelled out by the cancer organizations in India forming the National Cancer Grid, widely respected, non-controversial body. So I think it will be good, specifically in relation to cancer, it would be good to take a look at that. I would share one more thing with your permission. That will take only a minute. Sorry. You see the telehealth line that we have. Some of you are already in touch with this helpline. This is something that we run from 9:30 a.m. to 4 p.m. from Monday to Saturday. So if you can see here in the bottom on the left-hand side, there are two kinds of callers. One are healthcare professionals seeking advice. And so all of us have doubts coming up. In a place like ours, there are 5 or 6 palliative care physicians. We are able to consult one another. Still, we have 100 doubts, and we not infrequently ask Anne Broderick or our other supporters elsewhere. But especially for those who are working alone or in rather lonely situations, when you have a doubt, please ask. You have a doubt whether this is the right patient for whom we should use methadone. You have a doubt whether we should stick to amitriptyline or go to gabapentin. Whatever doubt you have, or here is the patient with intense breathlessness. What can I do? I mean, nothing seems to be helping the person. So please, you make use of the telehealth line. I have put in the number there. Please make a note of the number. and I think it will be good. We also learn from the consultations that we get, but I hope it can be used more. Thank you. Sunil, back to you.
Thank you, sir. So I think, are there any more comments? We can take one more comment, and after that, I think we will move on to feedback.
Okay, now that you have, I mean, I might as well bring up this also. Sunil, sorry about this. One more screen share. Just so that you all know, this is another helpline that we have called Sukh-Dukh helpline. It is run in 8 Indian languages. You can look at the Palim India website and it appears on the home page. By now, nearly 500,000 Indians have died of COVID, and a huge number, unknown number of people have died from other conditions due to poor healthcare. They are leaving behind a huge burden of grief. This is another helpline which is even longer running, 9:30 to 6:30 p.m. If you know people who are grieving, and if you think they are not finding enough support, extended families are not there, the rituals are not there, so the incidence of pathological grief is very high. So whether it's a relative or a friend or one of your patients' families, if they are in intense grief, please make use of this helpline. The 759-405-2605 is the number. Free, both the helplines are free. I hope you will, this is less visible, the grief is less visible. But if you ask people, they will tell you how much they are suffering. They can get some help from trained grief counselors. Thank you.
Thank you, sir. So I think we will move on to feedbacks from the participants now. So I would request anybody to start. So